fine. So next is Dr. Prasanna Venkatesh. He is already on the dais, Decoding Glaucoma Module Premium Edition. So his presentations are always more tech oriented, which is quite innovative at times, and we expect the same of this presentation also.
Thank you, ma'am, for the kind introduction. So this is Glaucoma Module Premium Edition from Spectralis. I have no financial disclosure, but this is from shifting the Brooks membrane opening horizontal rim width that we traditionally used to do in our OCT to shifting BMO MRW, that is minimum rim width. I have no financial disclosure in Spectralis, but let us start with an animation here. So this is a sliced OCT of OCT optic nerve. You can see that there is a green line which is the internal limiting membrane, and this is a three-dimensional slice of the same, and the red is the Brooks membrane. You can see that there is a red dot here. The red dot is a Brooks membrane opening, and usually we take the horizontal rim width, that is the distance from here to here. But now we are going to talk on Brooks membrane opening minimum rim width, that is the smallest distance between the internal limiting membrane and the Brooks membrane opening. So let us decode this Glaucoma Module Premium Edition, which is the new kid on the block for diagnosing OCT with glaucomatous patients. So I have used this template here. The blue is the RPE, the red is the Brooks membrane, choroid, and the green is the sclera, so that we can have this concept conveyed for neophytes in a much simpler way. So what is the true margin of the optic disc or the disc margin? So you can see that we tend to take the scleral ending, that is the green line. As you can see, I told the sclera is green. So we take this to be the disc margin that we see in a fundus photograph or in a direct ophthalmoscopy of fundus photographs. But in reality, in OCT, the definition changes where the termination of the Brooks membrane is taken as the disc margin, that is the red one, which is a OCT classification. As you can see, it is red. So now we are confused with two, whether it is the Brooks membrane ending or whether it is the scleral ending. So we can't have two, right? Because if you have two margins, one will be clinically assessed margin, which is, as you can see, which is marked as the green dotted line. Another one is the BMO based disc margin, that is the red dotted circle. So we will be ending up having BMO based disc margin and a clinically based disc margin. So we can't have two, right? Because there will be two areas, clinical disc area which is clinical and Brooks membrane opening area which is OCT based. So clinical disc area was larger than the BMO in BMO area in normal and glaucomatous size. It was well proved. So you cannot have two swords in a single sheath. You can have only one. So this study by Chowan et al., which is cited the maximum you can see, was a path-breaking study which put to rest all the confusion. That is, the true margin of the disc is not the sclera ending, it is the Brooks membrane termination, because no blood vessels and axons can pass through the Brooks membrane. So then Brooks membrane will be taken as the structural boundary of the optic disc. So let us see what is again Brooks membrane opening. So we all know about this image, right? I'm just comparing it to the Niagara Falls. You have to have a three-dimensional perception of this image, how the RNFL comes and falls into the optic nerve. Now this is what we see in reality. You can see the green internal limiting membrane followed up to the Brooks membrane opening, which is red line. Spectralis Glaucoma Module Premium Edition or GMP has 24 scan lines. You can see 24 scan lines. So it gives you 48 Brooks membrane opening positions. So what, again I'm just taking back you into this animation. The ILM is the green line, the red is the Brooks membrane, and the red dot here, I hope you are able to see the red dot, which is the termination of the Brooks membrane. So this is the red dot. I have kept my laser pointer there. So this is the Brooks membrane opening, that is a red dot. So you can see that in all 48 slices, for want of use we have 3 here, 3 here. So totally we have 12 slices. We can go up to 48 in your OCT camera, where you can see this red dot here. That is the Brooks membrane opening. Then what is Brooks membrane opening minimum rim width? So again I am taking you back into the basic sciences here. So we have the green internal limiting membrane, then the red Brooks membrane opening. So traditionally we used to take the horizontal distance between the green and the red. But now the concepts are changing regarding the minimum distance between the internal limiting membrane and the Brooks membrane opening. You can see the minimum distance. So that is called Brooks membrane opening minimum rim width. The yellow part here, you can see that the yellow three-dimensional part here, that's called Brooks membrane opening minimum rim width, which is the smallest distance between Brooks membrane opening and the internal limiting membrane. So when you go for a decision, right, it will always be against something else. So why not Brooks membrane horizontal rim width? Because traditionally this is what we were doing. the horizontal rim width. Now we are changing to minimum rim width. So let us see some review of literature. Brooks membrane opening minimum rim width yielded a higher diagnostic performance than its traditional counterpart, the horizontal rim width. Also, the sensitivity of MRW was consistently higher than RNFL and Brooks membrane opening horizontal rim width. And you can also see the amount of neuroretinal rim tissue in glaucoma, if you see in this study, where a method to measure, it also was consistent with the MRW parameter. The mean deviation of visual fields, the visual field, that is a functional correlation, and the structural one that we are talking, right, the BMO MRW, they also correlated well compared to HRW. You can see that MRW, it correlated well. Again, the RNFL also correlated well. Innately, every one of us, just like our fingerprint, we end up having different optic discs. That, my dear friends, is the challenge in glaucoma diagnostics, because we may not be having the same disc. Each one of us may be having a different disc, and God has made us that way. So that is where the curse also lies, because of the variability. Many disc sizes is a curse, because the size or the area of the optic disc will influence the neuroretinal rim. So that is where the game-changing BMO MRW comes in, because see this example, a very practical one. Imagine a large disc and a small disc having the same area. So this patient and this patient, finally the neuroretinal rim area is the same. If you see the blue area, they both are the same. But a large disc will always have a small BMO MRW, whereas a small disc will always have a large BMO MRW. So this is the game-changing marker that OCT is giving us, because the influence of the disc size on BMO MRW is always there, despite two areas being the same. So BMO area will always influence the diagnostic precision of BMO MRW, but not the RNFL which is passing into it. So these are some of the things which we need to know. One of the limitations in OCT that we need to keep in mind when we are actually evaluating a small rim thickness doesn't always mean that the RNFL is also damaged, because it works both ways depending upon the disc area. So again, always keep in mind, choose your RNFL if you see that the BMO area is very less, because as I showed you in this image, when the area is very less, as you can see in a small disc, that the BMO area maybe seem to be more larger. So at that time, you will always have to choose choose BMO MRW, and when the BMO area is more, you will have to choose RNFL. So these are simple tips and tricks that you need to keep in mind. And why GMP really hit very hard is, it's like a GPS. So I'll just show you an animation of how it works. So this is a single beam. You see this patient moving his eyes here. So whereas here if he is moving, you see, since there is a dual beam in spectralis, it never loses track of the tissue. So every time, again see this on this side, a single beam will lose focus on the section of the tissue that it wants to examine, whereas a dual beam, even if there is micro movement, it won't lose focus. It is like a GPS, same piece of tissue, even when there is a slight head tilt. Again, this is a real-time video of one of our patients where we took. You can see that with slight tilts also, the machine automatically aligns itself to examine the same piece of tissue, which we don't have with the traditional OCT machines. So that is another advantage. So every time, first it marks the center of the fovea, then it marks the center of the disc, or it is also called as Brooks membrane opening area. Then the fovea BMO axis is plotted, and then surrounding that you can see that the ganglion cell layers and RNFL is blocked. So the main crux point here is, even 1 to 2 micron meters difference, it will easily pick it up. In subsequent follow-ups, where especially early glaucomatous damages, we can pick up even head tilts, cyclotorsions, even these we can easily help pick it up. I'm just winding up. So this impacts in diagnosing subtle glaucomatous changes very early. So this is one of my patients here, where 2019 I thought the IOP is actually controlled. It was 15-16, but the patient tended to progress. You can see in 2020 and 2021 there was very subtle progression, where I had to even put him on another medication and bring the IOP, which was 16 to 17, to even low teens like a 13 or 14. So this really helps in game-changing glaucoma. And most of my talk that I covered here about Brooks membrane opening minimum rim width and horizontal rim width, it is there in my publication in IJO in April 2021 issue, as well as another publication in June 2022 issue in IJO videos. So thank you once again for giving me this opportunity. GMPE Spectralis is going to be the future glaucoma toolkit where it's going to cut the disc in a three-dimensional way, and it's going to make a mark in the structural evaluation and the way we are perceiving the structural orientation of glaucomatous damage. Thank you.
Your slides were quite interesting as always, Prasanna. Yeah, BMO that has been gaining importance since past about 6 to 7 years, I should say. There have been publications on it.
Yes, ma'am.
The way you showed that is spectrally and single beam, that is fascinating. There is not much question left. Actually, one comment I would like to make,
Yes,
that ganglion cell complex, that is also something which we need to look upon. Even if it is early glaucoma, then sometimes GCC gets affected. So we advise 10-2 also these days, instead of just 24-2 as we have been doing in the past. Funny question just to loosen the house, I shall like to ask. You, in one of the slides, I noticed that curse of the disc, you have put Dr. Krishna in. So it is Mahalaya which is started, and I am a Bong. So maybe Durga Devi or something would have been better. I think Prerna has a question.
Yeah.
I have a theoretical question that even in the Cirrus Zeiss OCT, is BMO MRW only measured or BMO HRW?
Ma'am, in Zeiss, I am still thinking, in terms of BMO HRW, because this...
You do have that red spot present in
the red spot is there, and even if you are there is always a manual measurement where you yourself can do the measurement of the minimum distance between the ILM and the BMO opening, the Brooks membrane opening, which will be the MRW. But the catch here I have no financial interest, but with Spectralis what happens is you measure the same piece of tissue in subsequent visits. So one practical point here I would want to make is, a patient comes today in a traditional OCT where the head is like this, a slight tilt will change the whole way we are going to perceive the slices.
And
so
even
that
the foveal Brooks membrane opening axis is there in Spectralis.
For BMO MRW is now coming up in all machines, but the APS technology, the anatomical positioning system, along with the BMO MRW, even with 1 or 2 micron distance, we are able to pick up an early glaucomatous progression, not damage. All of us will be picking early glaucoma and visual fields or OCD, but we think we have controlled the glaucomatous process, and the patient's IOP is 16 to 17 as one of my patients. Despite that, the patient was progressing, and that sign I was able to pick it up, and we may end up saving the patient's disability years. So that's what I wanted to highlight. Thank you, ma'am.
Any questions from the house, because we have enough time?
Sir, I titrate between OCT visual fields and fundus photographs, so it's like once in a year, sir. Yeah, I don't put them into a battery of investigations. Once in a year, I make sure I have at least one OCT, one fundus photo, and one visual fields.